Welcome to Adapting Class, and thank you for joining us. Today, we're going to continue with us talking about the NCLEX difficult concept mastering. These are content areas that are very frequent flyers, and you have to master them and to be in good shape to pass your NCLEX. These can be very difficult to think about them, but they're doable. So I just have a few questions and we'll talk about these topics. And these are something that you should feel comfortable. And one of them is this question, right? Um, they're going to trap you. You have to know the difference between um, postpartum psychosis, postpartum blue, and postpartum depression. This is what this question is trying to highlight. Which client should the nurse assess first? So that's the first question. A nurse is in a postpartum unit is caring for 4 clients. So which of these postpartum patients do you want to know? You got to know the difference between psychosis, blue, and depression and see which one is in trouble. The first patient, she's 3 days postpartum client who state, I felt sad, overwhelmed sometimes. Is there any priority information there? Should you worry about this patient? You got to be sharp, right? Bring your content and analyze it. You expect this finding? If not, then you got to pick it. A 2-day-old postpartum client who report difficulty sleeping, right? Have problem sleeping, weightlessness, and then decreased appetite. What do you think about this patient? Number 3, a 1-day postpartum client who says the voices in my head keep telling me my baby is evil. So what do you think about this patient? A 4-day postpartum client who complains of breast engorgement and mild pain. As you can see, if we bring your content, you know number 4 is unexpected finding. Your breast get enlarged after you have a baby because of breast milk. It's not a problem. Number 3 say the baby is evil. Okay. And number 2 say, hey, I'm weightless. I can't eat. I have difficulty concentrating. And number 1 said, I feel sad and overwhelmed sometimes. Put down your answer. Let me see what you think. Who of these patients should you be worried about? You got to be sharp. There's a blue there, there's psychosis, and a depression, and a normal finding associated with the postpartum breast. The most severe form is always the psychosis. Who is in psychosis? Somebody who is hallucination. He has disorganized thought perspective. The person who has thought perspective is number 3. But look at number 2. It talk about weightlessness and then what? Decreased appetite. That's something talking about depression, right? She's a little bit depressed, but not compared to this patient who has psychosis that will need inpatient management. So that patient is very serious. You should be more concerned about that patient than number 2. So that's the first question. A client present 24 hours. This requires you to test taking strategy and thinking about the question and also paying attention to the buzzword, right? A client present 24 hours after hiking. Hiking is the buzzword. Okay, pay attention to that. In the woods with the red, itchy rash and blisters shown below. Which infectious control measures should the nurse implement? These are some of the cases, questions you will see. They will give you images and then they will ask you what kind of infectious control. That's what they've been asking these days. So look at it. Look at this picture. Look at this picture carefully. What do you think? Right? This is the picture. I went to the woods. That's the buzzword. And I've been hiking. And I saw this in my hand. Think about what are the possible. And the buzzword is hiking. And this is the content. This is the way I want you to think. Don't rush and pick an answer. You see some blisters and vesicles and all those things. It's okay. The content here is I went to the woods. Therefore, you cannot have varicella over there, right? You can't have TB over there. All those things, you think about it. So when you're picking your answer, oh, you know, I went to the woods. What is in the woods? It's weeds. That means my skin touch a weed, right? And when you touch something, it becomes contact. And that became what? Contact dermatitis. That's all. When you see questions like that, they want you to think a little bit. It's just contact dermatitis. Then, since you know it's contact dermatitis, what kind of precaution? This is not a contact precaution, it's a contact dermatitis. You don't need droplet precaution, it's a contact dermatitis. Airborne, you don't need airborne precaution, it's a contact dermatitis. Contact dermatitis, you touch the thing and you have rashed it. If you don't touch it, you're not going to have rash. If me taking care of you, I've not gone to the woods, I'm not going to get the rash from it. Therefore, this is a standard precaution. So watch for these kind of questions and then you'll be able to answer them. This is the way they may ask you these questions. Okay? And this is performing initial newborn assessment. You have to know newborn. Peds and newborn are very troublesome, but it's a way you can master them. Focus on some of the key things about them, especially which assessment finding. If you don't know anything at all, assessment finding for newborn, they're going to ask you so that you can, when mommy asks questions, you'll be able to answer. Which of these should you what? Report it to the provider. Slightly enlarged fontanelle. When the NCLEX put adjective in front of something, they want you to emphasize on it. If I want you to worry about enlarged fontanelle, I will remove the slightly from there. Just a slightly enlarged fontanelle should not trap you. It means it's normal. It's slightly elevated. It's not high elevated, right? Respiratory rate of 50. You ask yourself, what is the normal for a newborn? It's 30 to 60. Therefore, this is normal. A heart rate of what? 120. You know, 110 to 160 is normal. And when they cry, it goes up to what? 180 is normal. Don't pick it. Cyanosis around the mouth is normal. It's acrocyanosis, right? But when it persists, when the kid cry, it means that is hypoxia. We should worry about that. Cyanosis around the mouth that persists when you cry. That means when they exert themselves, they become more hypoxic. Therefore, this is a problem. Jitteriness and tremor, indicate hypoglycemia. You should worry about it. Newborn temperature, what is the normal? 97.7 to 99.5. Those are normal. Hypothermia is key in newborn, so you have to know those numbers. It's the normal finding. Of course, in a case study, they will give it to you. In the standalone, you're not going to get it. So you still have to know newborn temperatures, especially everything about newborn. So this temperature is fine. How about last one? What do you think? Put down your answer. Single artery in the umbilical cord. How many arteries should you get in the umbilical cord? How many veins and how many arteries? What do you think is the right answer regarding that? Should we pick it or should we leave it? How many arteries should you get or should you expect in umbilical cord in a newborn? It's usually two. Therefore, we should worry about it. It's usually you need two arteries and one vein. Therefore, in a single artery, we should be concerned about it. So those are the answers. These are newborn pathology, is what we have. This is also therapy. Be careful. And this is assessing a 7-year-old client who has tonsillitis, right? Tonsillitis, that the newborn has tonsillitis. Which finding should require immediate follow-up? Difficulty swallowing, large swollen lymph nodes and temperature of 101, muffled hot potato voice, red beefy strawberry tongue. What do you think? If you're taking the NCLEX and you see this question, 7-year-old, he has tonsillitis, which finding should give you concern? That means you got to be sharp. Is there any airway issue? Is there any breathing issue? Is there any electrolyte issue? Is there any shock issue? Is there any neurological problem? Is there any pain issue? Look at it. Which signs and symptoms should concern you? Difficulty swallowing, large swollen lymph node, and a temperature of 101.5, muffled voice, and a large strawberry tongue. What do you think? It requires some content. Expected finding for this disease is right there. One of them is strawberry tongue, very large tongue because of what? Strep infection that can lead to scarlet fever. Therefore, big strawberry tongue is suspected. When your tonsils are so huge, you can, when you swallow, it's going to be slightly painful. So difficulty swallowing is because you have huge tonsils. So don't pick it. It's not an airway issue. It's a trap. I'm just giving you difficult concept for the NCLEX. You see this and you run away with it. You pick difficult swallowing because you think it's airway, but you forget that this is tonsillitis, right? Swollen, your lymph node is going to get huge. It's a sore throat. But when your voice change, remember your voice in your larynx, that's where it's located. When your voice change, that means now you're having airway obstruction. The tonsils is closing so much that air is not going through, so your voice change. So hot potato voice is your priority. So this one is dangerous. Okay. This is pharmacology. It's a straightforward question. It requires some strategy. The buzzword is what? Which of the following drug is contraindicated? That means you cannot take it. If you're taking what? Spironolactone. Look at the way I want you to approach it. You take the buzzword, which is spironolactone. Ask yourself, don't look at the answers. Ask yourself, what kind of drug is this? What kind of drug is spironolactone? What do you think? What kind of drug is spironolactone? Is what? Potassium sparing. Is a potassium sparing drug, right? So if you know the answer, you can put it there. You can type your answers. It's a potassium sparing. That means if there is going to be any contraindication, which medication will also lead to potassium sparing? That's all. Look at each of them and find out which one is potassium sparing. The name does not matter, but the class of the medication. So you start from the number one. What do you think? Lisinopril. Should we stop taking lisinopril if I take spironolactone? Tell me, what do you think? Put down your answer. You have 6, 7 answer choice. What do you think? Which one is contraindicated? Contraindicated means you cannot take it. This is always, people always make mistake. They interpret the question wrong. Contraindication means you cannot take the medication if you take spironolactone. Therefore, if I take spironolactone, I should avoid this. Try to interpret the question multiple times. If you take spironolactone, that means you should avoid potassium sparing. Lisinopril is a potassium sparing. You should not take spironolactone with it. See, that's the first thing. That's the first thing. Furosemide is not potassium sparing. It depletes your potassium. So it's okay to take furosemide with what? Spironolactone, because spironolactone get rid of your potassium and furosemide keep your potassium. So your potassium become normal. Metoprolol does not affect your potassium. Calcium channel blockers does not affect your potassium. Irbesartan, so Ebsartan, Satans, Sartan, I call them Satans. Satans are ARBs. ARBs are like lisinopril. They also causes potassium sparing. Therefore, you should not take it. The F is a medication that most of you may not know. Is renin inhibitor. We call it alixkirin. Alixkirin is a renin inhibitor. It also leads to potassium sparing. It's a renin, RININ inhibitors. They also lead to potassium hyperkalemia. Therefore, you should also avoid them, right? So these two, you should avoid them. Heparin can decrease your aldosterone, right? If you decrease your aldosterone, you're going to have high potassium because aldosterone get rid of your potassium and increase your sodium. So heparin can lead to hyperkalemia. Heparin-induced hyperkalemia. It's a new phenomenon for you. Yes, these are some of the, sometimes you see hard questions you see in pharmacology. These medications, I know you know them, but I put them in the question related to hyperkalemia. You may not have seen it. This is a key. So watch for them and then master them. So I'll give you the explanation there. So if you have on the mind, you will see it. A nurse is in the emergency room is caring for a client with anaphylaxis from a bee sting. This is a concept question. The client received what? IM dose of what? Epinephrine 15 minutes ago without improvement. What is the nurse priority action? How do you answer question? Read it from the back. What is the nurse priority action? That means you got to be sharp. You have 1 second. All these answers are possible, but there's one you have to be sharp about it. Then you go for the case. What is the case? A nurse in emergency room is caring for a client with anaphylactic what? Anaphylaxis from bee stings. That means he's been stung from a bee, right? And he's having anaphylaxis from it. What have you done? We give the patient IM dose of what? Epinephrine 15 minutes ago, but there's no improvement. What do you think we should do? That's all. Look at the answer choice. One said intubate the patient. Second, give them diphenhydramine. 3, give them epinephrine IM, and then steroid IM, IV. What do you think? Bring your content. Bring your content to answer this question. Is the content related? NCLEX will ask you that. There's a reason why this was created because it's very important in the management of a patient with anaphylaxis, right? The concept here is epinephrine can be given, right? It lasts for 5 to 15 minutes. In patients with anaphylaxis, you can give them every 15 minutes. If they're not improving, they can at least they can get a second dose because that's the most effective. If they don't improve after a couple of doses, then they get diphenhydramine. If that doesn't help, they get steroid. If that doesn't help, then they get intubation. I put intubation here to trap you, but you have to know the concept. After 1 dose of epi, you can give it again every 15 minutes, right? So this is your right answer. That's the priority. That's all. I'll give you a long explanation to give you reason why. The nurse is caring for a laboring client who is requesting IV pain medication. I am in labor. I need some pain medication. What is the which client is safe to receive what? Butorphanol. Another concept question. Everything I said, I want you to pick the concept. You don't have to memorize it for your NCLEX, but if you know this little concept, you know labor and delivery, this is something you have to know, that to give a patient in labor, you have to give them what? Narcotic. But then you have to know when is the best time to give them. So butorphanol is a narcotic, right? It's an antagonist and agonist of opiate. So it acts like opiate. So it has the features of opiate. What does opiate does? It's a depressant. So it will depress your nervous system. And so it can depress your respiratory drive. Second, you can only give this medication in active labor, right? Third, the patient should not have substance abuse. This is the concept. This is the way you should learn for NCLEX. Everything knows some few facts about it. So when you see the question, you use it. I see butorphanol. The next thing coming to my mind is what? Is antagonist and agonist. You should not have substance abuse. I can use it in active labor. You should not have anything that would depress your respiratory drive. Then I look at the first question. The fourth one, you should not be preterm, right? 38 is term, check. Patient is in active labor, check. Is 6 centimeters, active labor, and is not having substance abuse. Oh, that's a good one. Next one, 32 weeks. No, you are preterm. Therefore, I should not pick you, right? So that one is eliminated. 3, 40 term, right? Is 9 centimeters. So that is in the transition zone. That's active labor. Therefore, it's eliminated. D, 36-week-old. And I have what? I'm in active phase, but I have asthma. Asthma, you can have respiratory depression if you give them opiate. Therefore, that is one is not the right answer. This is a hard one, but I break it down so that you can know. I take my 4 content and I score them for each question. Try to answer questions like that. Therefore, A is the only person who has this. And I give you the explanation here, the reason why you cannot use it in this situation. But that's the content, exactly what I told you. And then observes a new graduate performing closed suction on a endotracheal tube. The word is closed. Don't run away from it. It's a buzzword. Just because you see endotracheal tube, you forget about the word closed suction. Closed suction means this is it. If this is the endotracheal tube, okay, and it is going to the patient airway, there is a side port, and the suction go here like that. So the suction itself, you don't see it. You're not going to contaminate the suction. It's completely covered. That's why it's closed. The open one is when you take the suction and you put it in the endotracheal tube. But if it's connected to the endotracheal tube, it's called closed. That means it's okay to wear a what? A clean gloves. And then observe the new graduate applying what? Clean gloves before suctioning. That is good. A new graduate set the suction pressure to what? 100 before starting the procedure. The pressure for adults is 100, sometimes 80 to 120. So, but most of the time, 100 to 120. This is okay. The new graduate suction the ET tube for 15 seconds while watching the monitor for changes in oxygenation. Even though the second portion is right, watching for change, 15 seconds is too long. Less than 10 seconds. 5 to 10 seconds is always a good thing. The new graduate upper oxygenate decline to 100%. That is good. Therefore, the one that need intervention is the suctioning. It's too much. But remember, closed suction need a clean gloves, not a sterile gloves. So this patient is in trouble. And next is caring for 4 clients. Which clients has the highest priority for delirium? The concept here is delirium. Bring your content. What is delirium? Acute change in sensorium of the individual is different from depression or what? Dementia. Look at each of them. See who meets the criteria for delirium. When they give you long answers, long question, don't freak out. Don't worry. Sit back, relax, chill. Go for the buzzword. Break each question, answer choice down. Knock them by one. You say, I know it's delirium. I'm going for the buzzword. That means what? Things that is consistent with acute change in sensorium, right? Number 1 is 72, old guy, risk factor, right? Who is post-op from hip replacement. He just had surgery. He's confused, but is oriented after brief reorientation. Number 2, 65-year-old client with the history of Alzheimer's disease, who is disoriented at times and respond to what? Verbal cues. Number 4, a 78-year-old client who is what? Being treated for what? Pneumonia, and is exhibiting what? Sudden agitation. You see, hallucination, difficulty following command, right? Number 3, 60-year-old client recovering from a stroke who has mild confusion and alert after rest. What do you think? What do you think? Go for the buzzword, like I told you. Use the buzzword, acute change in sensorium. So look at each questions and see if there is acute change in sensorium. They're not going to hide the answer. They have to be fair to you. It's a board exams. They have to make sure you pass. They're not there to fail you. The questions are vetted. They will make sure there's no trappy answers there, but they will put trappy answers too. It's both left and right. The trappy answers means they're trying to see if you pay attention, right? I told you, acute change. Who has acute change? You can see this guy is hallucinating, difficulty following command, and it's all over the place. That's the way you answer questions, guys. Mastering difficulty concept. Delirium is a concept you have to know. Somebody has a very long delirium question. It's a case study. You know, they will try to pull you up and down, stand your ground and said, no, I know this patient has acute change in status. I'm sticking with it. I'm not changing my mind. And then she's teaching a client about what? Advanced directives. I told you, how do you read question from the back? Select all that apply. What? Which of the following statements indicate a need for further teaching? Circle the need for further teaching. Circle it. I've circled the need for further teaching. I tell my mind, they're saying something wrong. They're saying something wrong 3 times. Then I'll look at the question. What is the question? And then she's teaching the client about what? Advanced directives. That means they're saying something wrong about advanced directives. There's another key word here. If the NCLEX said advanced directives, there's 2. There's a durable power of attorney. Okay, so there's 1, then living will. Don't forget, don't separate them. Unless they tell you it's a living will, answer the question regarding living will. If they tell you power of attorney, heir proxy, answer the question about heir proxy. When they use the word advanced directives, that means they refer to both. So if you see answer choice related to heir proxy, pick it. Answer choice relating to living will, pick it. That's all. So what is happening? Further teaching. Once again, don't forget, I can designate someone to make decision if I become unable to do that. Heir proxy. That's what he's referring to. That is fine, right? That's no problem. Once I complete an advanced directives, I can't change it. That is not true. You can change it when you assign somebody. You can change your mind no matter what until last minute. You can change it. So this one need further teaching. You should be able to change it. My advanced directives goes into effect only if I'm unable to speak for myself. Content. The word is advanced directive. Look at it. Don't freak out. Don't make it hard. Advanced, that means you make a decision ahead. Directives, you teaching the person what to do. I'm telling you what to do in case of emergency. That means if I'm able to make a decision, then you're not going to make it for me. That's what he's saying. My advanced directives go into effect only if I'm unable to make decision for myself. Nothing wrong with it. I should give a copy of my advanced directive to my healthcare provider, right? Yes, they need to know what are your wishes. Advanced directives are only for people who are dying. No. If that's the case, then C and D are wrong, and one is wrong. It's not that you're dying. The word is advanced. You make a decision ahead in case you in emergency or situation when you are not able, then somebody will make it for you. Or the one that is written down, which is your living will. Therefore, it's not only for dying. You can be healthy and make a living will. Therefore, this we need to intervene. So that one is bad statement. You see how they can trap you. You are not dying. You don't need to be dying to make advanced directives. Okay, I hope you guys understand that. And next, working in the clinic, receive message for 4 clients. The client should, which client should the next call back first? Prioritization 101. If you need prioritization, I have a bunch of videos. I have so many free videos because I feel like you got to be very comfortable with prioritization. Every question, there's a prioritization here. And how do I teach you? I said, be sharp. You have 1 second. Everybody is a priority. But who does not have time? Not an expected finding. You need the content to know the expected finding. And within the expected finding, look at the one when you see it, you know patient is dying. Is he a breathing, electrolyte shock, sepsis, airway, and pain? And what is the pain? Pain that is going to take your life, limb, eyesight. Who need to be seen first? I'm taking phenotime. My tongue, my gum is swollen, and I'm dizzy. What do you think? I'm taking methotrexate. I have mouth sore and I have low-grade fever. 3, I'm taking clozapine. I report fatigue and sore throat. 4, I'm taking sildenafil and I have headache. Put down your answer. Let me know how you're thinking. Let me see what you think about this prioritization. Who do you think need your time? 1 second. If you're taking care of the patient, who do you think? Do you see an airway issue? You see sepsis? You see breathing? You see pain? You see neurological problem? Who do you think you need to see? Right? Then you go back to your content. You ask yourself, which medication is dangerous? What signs and symptoms are associated with the medication make you worry? Make you worry. Think about it. Phenotype. The major side effect is what? Stevie-Johnson syndrome. I don't see Stevie-Johnson syndrome there. I see what? Gingival hyperplasia. That means swollen gum. I'm not worried about it. And dizziness is ataxia. I'm not worried about it. Methotrexate is an immunosuppressant where it can cause myelosuppression, and that can give you mouth sore and low-grade fever. It's serious. Pay attention. Clozapine causes agranulocytosis. You have sore throat. Really bad stuff. Sildenafil is going to cause headache. And as you can see, A and D are okay, not bad. B and C, now you got to find which one is more serious. You take methotrexate and you have mouth sore and you have low-grade fever, or clozapine, you have sore throat and a fatigue. Clozapine, agranulocytosis is so dangerous than having myelosuppression. Therefore, that trump that one. So that's your answer. And the last one, right? And this is caring for a laboring client who is receiving an epidural for pain relief. Which of the following findings should the nurse report to the provider? Immediate, that means prioritization. The content here is, don't even look at the answer choice. What is epidural? If I give you epidural, what are the signs and symptoms? And which one is dangerous? That is the way I want you to practice answering question every time. Ask yourself, if you can regurgitate those information, then you look at the answer, it's like a breeze. You just walk through, you feel confident. When you go to the exams room, you know, epidural, I know the side effects, right? I know everything that is going to happen if I give you epidural. Which of this should you worry about? Put down your answer, let me know. Which one you should report it to the provider. Client report feeling pressure during contraction. Client became pale and reported nausea, mild itching at the epidural site, decreased sensation in the legs. Who is in trouble? We know that biggest side effect is epidural is hypotension. Most of the medication may be opiate or something, whatever they will put it in it, but it can cause numbness of your leg. It can also what? Um, you have itchiness at the site, right? And so, and if you're using a epidural, you can decrease your contraction so you can feel some pressure there. But the most serious side effect you can see is hypotension. I see hypotension there, but I do not put hypertension. You think NCLEX won't do that? They won't put hypertension because they put hypertension, you pick it. Which of these patients is hypertensive? Pale and nausea are signs of hypertension. And therefore, this is your answer. This is Adapting Class. Thank you for watching. If you like this video, with the like button, you can just click on it. If you like it, you can subscribe to our channel to help the channel grow. If you want to join our membership, it's very cheap, one of the cheapest on YouTube. You get a restricted video. Or you can join our on-demand for crash course that is coming up in May. Check the communication post. You see the flyer. Take care of yourself. Good luck and never stop charging. I know one day you'll make it. Bye.